Namaskar, good afternoon, good evening, depending on wherever you are. On the occasion of World Health Day, wishing you all a very good health. It's my pleasure to welcome you all on behalf of the National Data Quality Forum, NDQF, hosted at the ICMR National Institute of Medical Statistics, to the webinar series organized to discuss and disseminate information on measures being taken to ensure good quality data. My name is Sarita Nair, and I'm a scientist with the ICMR National Institute of Medical Statistics. And I will be moderating today's webinar on availability and quality of mortality statistics in India, current appraisal and future prospects. Information pertaining to mortality statistics, including cause of death, are essential for development of effective public health policies and programs, and also to measure their impact. Although the civil registration and vital statistics system is the optimal source of the mortality statistics in India, limitations in its functional status have restricted direct use of the CRS data for mortality measurement. Today's webinar examines the operational characteristics of the CRS system in terms of design, data availability, and quality, and discusses the way forward to enable the CRS to fulfill its goal as a reliable data source of mortality statistics in the country. Thank you all once again for joining in. As we start, a couple of guidelines to ensure a smooth session without any glitches. For this session, all the participants will be, except for the speakers, shall be on mute. We'll be taking chat-based questions, and the chat box will remain live throughout the session. Please feel free to type in your questions anytime during the session. Our esteemed speaker discussant would address those towards the end of the session. Thank you. Before I invite Dr. Chalpati Rao to deliver his talk, it's my honor to introduce Dr. Rao. Dr. Chalpati Rao is a research academic at the Australian National University. His key interests lie in the collection and analysis of cause-specific mortality statistics for health policy and research. His experience covers field projects for mortality data collection and validation, as well as secondary data analysis for countries in the Indo-Pacific region. His work in India includes research on cause of death in Andhra Pradesh, verbal autopsy validation in Delhi and surrounding areas, subnational mortality estimation using data from the SRS and other sources. His current work focuses on design and implementation of activities to strengthen national civil registration and vital statistics system for mortality measurement. Over to you, Dr. Rao. Can't hear you, sir.
Good afternoon, everyone. At the outset, I would like to thank Dr. Sarita Nair as well as the organizers from the National Data Quality Forum for providing me this opportunity to interact with all of you on the subject of today's session. My talk today will comprise a little bit of a background about mortality research in regard to the various perspectives and disciplines involved in this subject. I shall then go over the salient features of mortality data sources in India, and then there will be a deep dive into the design characteristics of the civil registration system, along with the examination of data availability and quality from the system in recent times. I shall also present some outcome indicators from recent analyses that were done for the data for 2019. And I shall conclude my talk with a few recommendations as to what could be done to further improve the quality and availability of mortality statistics from this year. Well, to start with, I would like to reiterate, and I'm sure that most of you or all of you would agree with me, that mortality research is a multidisciplinary science. The analysis of the levels of mortality and its causes lies at the intersection between the two broad disciplines of demography and epidemiology. Along with fertility and migration, analyses of mortality levels and causes are integral to understanding population dynamics and change over time. Similarly, the information on causes of death and mortality patterns is an integral part of descriptive epidemiology, and also the endpoints of mortality are important for observational studies, case control and cohort studies, as well as clinical trials in clinical epidemiology. So therefore, the collection and analysis of death registration data in particular is even more multidisciplinary in the sense that it involves the administrative, clinical, social, data management, and statistical skills. Each of them have their own unique contribution to the whole subject of mortality statistics. And I anticipate that the participants in today's session would include representation from most, if not all, these fields. A quick overview of the three main population-wide mortality data sources in India will set the stage for a deeper examination of the civil registration system. So, as we know, the CRS is actually implemented under the Registration of Births and Deaths Act from 1969, and currently it covers the entire country, of which the population of which was estimated to be around 1.36 billion in 2019. On the other hand, the sample registration system, which was established in the 1970s to serve as an alternative and interim data source while the civil registration system was under development, covers a population of 8.1 million, which is barely 0.6 of the national population, 0.6%. The sample registration system was designed to measure infant mortality rate at the level of the natural division within a state within a 15% relative sample error. The third source is the periodic National Family Health Survey series, the fifth of which we had most recently. It included a sample of 640,000 households, and it included a household questionnaire in which the mortality module asked questions about deaths in the household within a 3-year recall period. The objective or the outputs of the CRS are that it produces deaths by age and sex for all states, and at the level of the district, it reports total deaths by sex. The SRS reports age-specific death rates by sex for India and its larger states, and the NFHS reports district-level under 5 mortality rates, and also makes available the raw data on the household deaths that had been recorded during the survey. In terms of the actual mortality reports, the CRS captured 7.64 million deaths in 2019. The SRS records about 50,000 deaths each year, and the NFHS recorded around 75,000 deaths in the survey over a 3-year recall. The CRS also collects information through medical certification of cause of death, which covers about 22% of the death, as well as the death report form, which we shall be examining in a short while, also includes a report of the cause of death from the family. The SRS collects data using verbal autopsy on the causes of death, whereas the NFHS does not report causes of death. Broadly speaking, the CRS carries bias from low completeness in some areas. The SRS is affected by sampling error, which is relatively high, as well as potential problems with completeness of reporting. And the same applies to the NFHS as well. So in this environment, it is clear that the civil registration system carries many advantages, the most important of which is its complete national coverage and its massive sample size in terms of the numbers of deaths that are recorded. So when we examine the characteristics of the civil registration system, the first and fundamental aspect is its legal framework. As mentioned earlier, the Births and Deaths Act was enacted in 1969, and there are revisions that are made to it from time to time. The CRS follows a decentralized model with multiple level administration across the center, states, districts, and local level. Each state publishes its own rules for implementation, as you can see in the example given here of the Andhra Pradesh registration of births and deaths rules in 1999. And these rules are the ones which specify the various institutions that will be responsible for implementing the CRS, the personnel who are designated as registrars, notifiers, etc., and the various forms and procedures that are to be used in implementing the CRS. Also, medical certification of cause of death as per the WHO principles commenced in Mumbai in 1950 and is currently mandated for all medically attended deaths across the country. If we examine the law in detail, we find that there are specific clauses that give importance to the aspects of coverage, who shall be the notifiers, the reporting period within which events such as deaths should be reported, the rules that govern cause of death reporting, the issue of death certificates, and the maintenance of records and statistics. In summary, the Act and the rules together provide a comprehensive basis with all relevant details for implementing the CRS. In terms of its current updates, the coverage of the CRS is now complete with all the latest procedures and registrations forms since 2009. Medical certification has now been mandated by the Registrar General to cover all hospitals in the country in 2014, and this is now being implemented across the country. And in regard to the maintenance of statistics, the circular has been released in 2018 to mandate the calculation of vital rates at the district level, which is an important advancement for improving the availability of data. In terms of the administrative structure and organization, there is considerable heterogeneity in the registration machinery at each level, which I'm not going to go into the details, but we have involvement of the health department, the departments of economics, statistics, planning, local administration at the state level. At the district level, we have medical officers, collectors, magistrates, statistics officers, and panchayat officers. And in the rural areas, there are officials from even the education department, revenue department, and police department who conduct the functions of registration. So if we examine it state by state, we can see the variations in the institutions that are running the CRS across the states. And one can immediately see the kind of complexity and intersectoral collaboration that would be required to ensure that the functionality is good. So initially, this complex structure evolved because of the fact that each state had its own administrative structure and resources that were available at different levels, which sort of guided the selection of officers and personnel. But we can see that despite the complexity, there are functional intersectoral collaborations in most of the states, which is understood from the relatively high levels of completeness of death registration. Currently, there is a need to increase health sector involvement at the local level to strengthen cause of death attribution. If we look at the forms that are used for reporting deaths, the first distinction is also to understand that there is a separate form for reporting the death, and subsequently the registrar issues a death certificate to the family. People tend to confuse between the two, the death report and the death certificate, which leads to misinterpretations. As can be seen from the slide, the death report includes several very important variables, including the place of occurrence, the place of residence, the statement as to the cause of death as reported by the family, information on whether the death was associated with a pregnancy in women of reproductive age, as well as information on smoking and tobacco use and alcohol use, I'm sorry, and whether the death had occurred in a hospital. So these bits of information are important for mortality analysis in general. However, we should remember that death statistics in India are reported according to the place of occurrence, and this has important implications for the use of the data. This slide also shows the birth report and the stillbirth report, and these forms also include very important variables, including the sex of the baby, the residence and occurrence as to the nature of the characteristics of the mother, the education and the age of the parents, the type of delivery and the medical attention that was sought at the time of delivery, the number of children, the birth weight, duration of gestation. So as you can understand, all these variables are what we actually collect in the SRS and NFHS to do analysis. But we can now see that the birth reports for all births in India actually record all these variables to varying levels of accuracy, but at least in terms of design, the data is available. And for neonatal deaths, the birth report has to be submitted along with the death report. So the information from both can be used for mortality analysis. Over the past decade, there have been several developmental activities that have enhanced the functioning and the performance of the CRS. The first of which was this publication of a training manual in 2012, which included detailed instructions and guidelines, and this was disseminated to all field functionaries. It has been translated into several languages. There are also several activities that are mentioned in annual CRS reports about training, inspections, and computerization of CRS in several states. And it has also been observed that health departments are getting more involved in CRS activities in several states, along with updates to various rules and processes as mentioned earlier. In terms of data compilation and release, the CRS publishes its annual vital statistics report. The latest was released in 2019 June 2021, I'm sorry, to cover the data for the year 2019. There are several important tables about the reporting as well as the data that is produced from these reported in these civil registration reports. I shall go through some of the important tables in the next few slides. The principal table for mortality analysis is this one, which shows the availability of information on deaths by age and sex that had occurred in Karnataka state, in rural, urban, and total. And these data are of critical use in analyzing age-specific death rates and life tables and other outputs. In 2019, such age-specific details were not available for 6 states, in which they were only providing reports of total deaths by sex. Another aspect is that the age groups that are reported here are rather coarse. There is insufficient detail, particularly for the final age group, which is truncated at 70 years and above. And this is not ideal for calculating life expectancies. And as mentioned earlier, since the data are according to place of occurrence, the urban-rural distributions and biases can affect the quality of analysis. When we look at the age-specific data from these reports on deaths in terms of mortality rates, we usually apply just a rule of thumb and eyeballing of the trajectory of the age-specific death rates to see if there is a smooth exponential increase in mortality, particularly beyond the age of 25 or 30. And as we can see, the death rates for males in Gujarat and the females from Andhra Pradesh are relatively smooth and ideal in terms of plausibility. But if we look at the death rates for the males from Madhya Pradesh, we see that there appears to be some degree of age heaping, as well as there seems to be some underreporting in the final age group, whereas there should be an exponential increase in the line. It seems to be tapering off. And the same was observed for females from Haryana, which one tends to think that such trajectories are suggestive of implausible death rates. At another level, when we look at the actual reporting performance within the civil registration system, firstly, you can see from this table that there are 284,000 odd registration units across the country where births and deaths are being recorded and the reports are being submitted from the village to the sub-district, district, state, and to the center. The coverage of reporting is quite high in most of the states, except for some of the northeastern states, as well as Jammu and Kashmir, at least in this slide. The data for the remaining states I didn't show because this is just to show a sample of the nature of data available. We can also see the gross differences in the population coverage between the civil registration and the sample registration system, and concomitantly, the gross differences in the number of deaths that are available from these two systems to actually analyze mortality rates. You can imagine the kinds of sampling error that are produced in analysis of SRS data, which we shall again see shortly. However, the actual quality parameter of CRS data lies in the analysis of its completeness, which refers to the proportion of deaths that occurred and were recorded in the population out of all those deaths that were estimated to have occurred in that population. As you can see from this slide, there are several different methods that are available. I'm not going to go into the details in the interest of time, but in the CRS context, we can directly apply methods A, B, and C. And the Adair-Lopez method is an important one given its recent development in 2018 and provides a useful alternative to evaluate the findings from the Registrar General's method. So when we compare the findings from the application of these two methods to the data of the civil registration system for 2017, there is generally a reasonable degree of correlation between the findings from the two methods. Of course, we must realize that the Adair-Lopez model can be used to derive sex-specific measures of completeness, whereas the ORGI method usually reports only the completeness for both sexes, which is not very informative. We see that the correlations are present even whether the death registration completeness levels are high, as in the case of Maharashtra and Odisha and Punjab, or low, as in the case of Jammu, Kashmir, Jharkhand, and Bihar. However, these total measures of completeness mask the variations that could be there in completeness by age and sex. So we further evaluated the quality of the data. As we know, the SRS and the NFHS are specifically designed to measure under 5 mortality, and we can have great confidence in the reports of the under 5 mortality rates from these two systems. So when we plotted the under 5 mortality rates derived from the CRS with against the values from the SRS for each state, we found that there was gross underreporting of the CRS in all states virtually, which is why the dots are all concentrated in the upper left quadrant, indicative of the degree of underreporting in the CRS. For adult mortality, we calculated the risk of dying between the ages of 30 and 70 years, and we compared the values that were derived from the unadjusted or raw CRS data with similar values that had been derived from a range of other sources, including the sample registration system and findings from the global burden of disease estimates at state level for India, as well as another exercise in state level mortality estimation called the National Burden Estimates that were also reported for 2017. We also evaluated these against a modeled mortality distribution using a WHO model life table system. As can be seen from this plot, in many of the states for males, you can see the red diamond representing the CRS value, the unadjusted CRS value, and it turned out to be considerably higher than the values derived for the risk of dying between 30 and 70 from the SRS particularly, as well as from the GBD and the other modeled distributions. And this sort of indicates that the CRS data tells us much more about the likelihood of death at these ages than the other systems. And this is a matter of worry that we may have been underestimating the levels of mortality at these ages in India. This slide examines the sampling error in the risk of dying between 30 and 70 from the SRS as compared to the civil registration system. And we can see over here that there is statistically significant difference in the levels of risk of dying between 30 and 70 in several states. So the SRS estimates are not only low, but they are also significantly low in many of the states. And this is also a matter of concern and sort of drives us to think that we probably need to pay much more attention to data that is coming out from the civil registration system. Even if we examine the data in the elderly, you may remember the previous slide in which I showed that in some states there is an underreporting of mortality, and that can be perceived from the relative tapering of the death rates at these ages. But we also observe that for some states, as can be seen for Karnataka in this slide, the civil registration death reports at ages between 70 and 85 were considerably higher than those reported from the SRS. And we had interpolated the deaths above 70 years, which were available from the CRS, using the proportionate distributions by age from the SRS to make this comparison. But we can see here that the factor of underreporting or underestimation from the SRS carries over from the 30 to 70 years to even into the elderly in some states. We also need to look at the fact as to whether there could be any bias in the CRS data. And one source of bias is delayed registration, meaning thereby the occurrence of death in 1 year, but its registration in the following year, in which case there might be an artificial inflation of the number of registrations in that particular year. We looked at the patterns of delayed registration, which are available from the annual CRS reports across all the states. And we found that there was generally a consistent pattern in the proportions of delayed registrations over the 4 years for which we had done this study. In a few states in the Northeast, there is considerably high and consistently high patterns of delayed registration. In these states, actually, the CRS data completeness is also low, which requires modeling to be done to actually estimate mortality in these states. And for several states, they do not provide the information on delayed registration. But on the other hand, we also see that there are states like Rajasthan and Tripura and Uttarakhand where the delayed registration is sort of at a consistent level across the years. And there could likely be a carryover effect, which might reduce the potential for bias arising from delayed registration in the data. Eventually, we analyzed the civil registration data for 2019 to also make some corrections to the reported data. So the CRS report was published in June 2021, for 2019, and it stated that the completeness was 92% as per the ORGI method. We evaluated the data for age, sex variations and completeness in each state or union territory according to the three broad age groups of under 5, 15 to 60 years and above 60 years. We derived adjustment factors through rate ratios between the observed rate and the expected rate and used those rate ratios to correct for underreporting in each state. We combined those adjusted death data with population estimates from the National Commission of Population Projections for 2019, derived from the 2011 to 2036 set, to construct life tables for each state. And when we compared our findings of life expectancy at birth with similar values that were reported from the Global Burden of Disease subnational estimates for India in 2019, we found that the GBD life expectancy estimates were rather higher than the life expectancy estimates from our study. In other words, the GBD had predicted lower levels of mortality than what we had found from adjusting the civil registration system data. And this also is a matter that requires further attention because this information on the levels of mortality in 2019 is important as it serves as a baseline to understand the impact of the COVID-19 pandemic in 2020 and 2021 when we want to try and evaluate the pandemic effects in terms of excess mortality. We require some sort of a baseline, and we'd like to have a reliable baseline for such an evaluation. Examining the functional performance of the MCCD scheme, the medical certification of cause of death, as I had mentioned earlier. In 2014, the ORGI had mandated implementation across all hospitals of the country, and this is currently in progress, with some states achieving complete coverage, such as Maharashtra and Rajasthan, whereas other states such as Gujarat and Haryana and several others, the coverage of hospitals is still yet has a long distance to go. We also know from the sample registration system estimates that in 2017, about 44% of deaths actually had received medical attention at the time of death. So logically, they should have all had medical certificates, whereas we had them only for 22%. And improvements on this aspect require administrative follow-up along with training of doctors in completing their medical certificates of cause of death for patients who die under their charge. So after looking at the design and functional characteristics and the performance of the CRS, what do we have to do and what are the future prospects for mortality estimation from the CRS? A few simple realities about CRS mortality data systems in general across various countries from my experience. Traditionally, we have found that the data recording and compilation in civil registration systems is too far removed from its analysis and used. And these are functions of data recording and compilation are vital for good quality data, but they never receive much attention. This includes the functions of the village level notifiers, the compilation of data at sub-district registration offices, and also the medical certifiers who sometimes or frequently do not pay adequate attention to the quality of medical certification. There are also various disparate factors that influence data quality. There are administrative factors such as the availability of infrastructure and technical and financial resources, as well as governance mechanisms that can affect the functional performance of the CRS. There are technical factors such as the quality of procedures that are used in data reporting and compilation, as well as the training of human resources in implementing CRS. And finally, there are societal factors that affect data quality in terms of community participation. There have been several attempts to try and get improvements in female death registration or the reporting of infant deaths, and this requires participation from the community. It is understood that these are sensitive events which are usually associated with considerable grief and trauma. And however, there needs to be a better mechanism by which these events could be notified to the local registrar in a empathetic manner. There's also a need for political will that will drive the provision of relevant resources and as well as administrative attention to the strengthening of civil registration. Eventually, only local level systems, quantitative and qualitative performance assessment will tell us what actually needs to be done in each location in terms of system strengthening interventions. In this slide, we see that the annual civil registration report actually does report the numbers of registered deaths at district level. And this, I think, is a very good and important starting point from which further build up of the system can be implemented. As you can see, the sample sizes of the numbers of deaths that are being registered each year in each district are quite huge, with many districts having more than 7, 8, 10,000 deaths. And this is a very big sample for calculating various mortality indicators. And they can enable very detailed analysis with high precision. Even if you have good quality data for infant deaths, it will provide precise measurements at the district and even sub-district level as compared to the rates that we get from the SRS and NFHS, which have considerable sampling error. There is also a potential to strengthen cause attribution at death registration at the district level to local interventions to increase medical certification for attended deaths and verbal autopsy methods for domiciliary deaths. In this slide, I present here a range of research topics in a framework that could be implemented for strengthening the quality and utility of data from national mortality statistics programs. These research themes cover program management, data quality evaluation, mortality outcomes research, and health policy analysis. And these topics, if taken up at the local, district, and state level at varying levels of intensity, can play an important role in strengthening the system. So in conclusion, we can say that the Indian civil registration systems seems adequate in terms of design and functional status, with regular availability of death counts by age and sex from all districts. There are some gaps in data quality in terms of incomplete reporting of infant deaths and female deaths in some states. There is inadequate reporting of age-specific deaths from some states, and also the age groups for death reporting need to be expanded to allow more finer categories for life table and other analysis, and there are inadequacies in cause attribution. In terms of the future prospects, I propose that it should be feasible to establish district-level CRS models in each state, in which function activities would be conducted in terms of systems assessment and design, particularly to integrate health sector functions. This would require some resource allocation to enable representative sampling of districts in each state to develop these models. There would be a need for capacity building, as well as the routine operations research that was mentioned in the previous slide, along with the functions of monitoring and evaluation, and data analysis to derive interim mortality statistics within 2 years of initiation. And this can give the proof of the implementation success and the sustainability, which can then lead to scale up of the coverage of the model across all the states. So that's all I had to say for now. And I feel that probably Professor Saikia might have more points that can further illuminate on the availability and quality of CRS data. I thank you all for your patience in listening to me till now. Thank you.
Thank you, Dr. Rao. That was an elaborate presentation on the CRVS system, the recent advancements, and also your critical appraisal of the data quality in CRVS system. So now, before we move on, I request for the discussant, Dr. Nandita Saikia. I'm sorry. Before I invite Dr. Nandita Saikia, a distinguished discussant, I have the honor of introducing her. Dr. Nandita is a professor in public health and mortality studies at the International Institute for Population Sciences, Mumbai. Before joining IIPS, she was an assistant professor at the Center for Study of Regional Development, Jawaharlal Nehru University. Her research interest is in formal demography, mortality and cause of death statistics, socioeconomic and regional inequalities in health, disability analysis. Dr. Saikia has published extensively on population health issues in reputed journals, and she's a proud recipient of several prestigious awards like the RSSS Fellowship at the ANU, Queen Elizabeth Advanced Scholar Fellowship at the University of Toronto, postdoctoral fellowship at the International Institute for Applied Systems Analysis, just to name a few. So I invite Dr. Nandita to kindly express her perspectives. Before that, may I request the audience to kindly type in their questions on the chat box? Thank you.
Yes, thank you, Dr. Sarita, for your kind invitation and to speak in this seminar. Am I audible? And can I share my screen?
Are audible. Yes, you are audible.
Yeah, please allow me to.
Yeah, now we can see your slide as well. Please put it on slide share mode. Yeah, thank you.
Yes, thank you so much. In fact, it is a privilege to be part of this seminar. And I think, how can I change my slide?
Ashni, can you please help?
I'm not able to change my slide.
Yeah, please hold on for a second.
Yeah, the arrow key should be able to help you out. Otherwise, you can exit slideshow mode and simply scroll through your presentation.
Exit, no, it is not. It is when not exiting.
Would request you to kindly close your presentation and restart it again. Maybe that could help.
No, it is not responding. Yeah, now it is. Yes. Yes, thank you. So I think to this audience, I don't really need to tell what is the importance of high quality mortality data. In short, it has been said that data is the new oil because it is shaping the world, particularly Twitter, Epic, or other big data sources are helping to are influencing global leaders and able to analyze market, people's psychology, and then influence global health business. But for a country like India, we have special purpose. What we do in demography, that is of course for the stream or health, but in general, for a successful demography, we need high quality, transparent data. And also we can evaluate different government policies, and particularly mortality data is more important because compared to any other data, mortality data are more objective in nature. It can speak more details about inequalities that exist across group. why this has been changed. I'm again not able to change this. Stop. Can you stop my screen? I will just speak like that. Are you there?
Or Roshni, can you play the slides?
Yeah.
No, you can
Would you
just
like to share your
stop
screen?
sharing. I will just speak because I think there
Yeah,
is a
we can't see your slides anymore. This is fine.
Are you able to
You no
change
longer
this?
have the presenter access.
Can you?
We are able to see your screen now.
Yes, but I'm not able to change the slide. Can you stop it so that I can just speak, but I can see my slides at least.
Sure. Done, ma'am. You can start your presentation. You can start talking.
Okay, but I think so. This we have many other statistics, mortality statistics. India, as all of us know, census can give direct, indirect information. Health management information system of India is collecting mortality data. SRS has as mortality statistics since 1970 at national and state level. NSSO also collects some mortality data, although not well analyzed. And finally, NFHS. We all know that NFHS has been collecting for last 5 rounds of data, and which are actually very impactful for our maternal and child health policies. But even then, we need CRS, civil registration system data, because all these data sources, what we have discussed, cannot give accurate adult and old age mortality, particularly at local level. And at local level, it is very important, because particularly for India, because India is a very big and diverse country. What is happening at state level is not always true at district level. And also, Indian districts are very big in size. So therefore, we need data, mortality data at local level, either district or even at block level. And as Professor Rao has already pointed out, that SRS and NFHS cannot be the permanent solution for India, as India progresses towards low mortality country, like where India has been experiencing life expectancy, increase in life expectancy consistently since 30 years, except this COVID time, where we don't have proper data. Because of low mortality status, related sampling error are supposed to increase more in near future, and the cost of conducting a sample survey to measure mortality will be just increasing over time. And not to say about this disaster situation, and when I think CRS, the value of CRS have become more, in fact, during the COVID time. We know that official statistics of COVID-19 is not enough. It is observed that COVID-19 and mortality estimates are hugely underreported, underestimated. But because of we don't have proper robust CRS data, we have to depend on an estimated deaths using different models. But again, and although being statistician, we use that we use always estimated. We use always different models to estimate deaths or so on. But it is these kind of models are also very sensitive to different assumptions, and depending on assumptions, it is not it is always like it can be inflated or deflated. And so there will be definitely a lot of bias in this kind of models. So to prepare for future disaster, also we need a very strong or robust civil registration system data. And I am very happy to have Professor Rao to speak on this topic, because Professor Rao has been working on civil registration system data of India. Most of the publications on CRS in India is done by Professor Rao, and he has experience of working not just in India and CRS, but also CRS for other countries. So as a discussant, my job is to summarize what Professor Rao has spoken, and then of course I will try to add some points from my side. So his talk is extremely relevant, and CRS is needed to evaluate government schemes at local level, and compared to mortality statistics which are existent in India, he has shown why CRS importance has been increasing over the time. And he also gave the very detailed outline of legality of CRS, administrative setup, and forms of CRS. He has given extensive details of CRS in a limited time. He compared SRS data and CRS data in well-performed states. Of course, SRS and CRS is not comparable in the states where coverage of mortality, death registration is low. But in the states where both systems are doing well, he found that there are more advantage for CRS. Also, he presented the coverage of CRS at state level using Ellen Lopez method and ORGI approach. And finally, he spoke about future prospect of CRS data. So when we talk about any data quality issue, we basically see the 6 characteristics like accuracy, what is the validity, and what is the reliability, timeliness, and relevance and completeness. While accuracy indicates the capability to provide the correct value of measurement, like whether data and whether civil registration system is able to record the correct deaths or not. Then secondly, validity. It ensures the consistency between period, space, and similar organizations. And so when it comes for validity, it seems that from his talk, it seems that from his talks as well as from our review of literature, it seems that CRS is not able to maintain consistency between period, because there has been increasing coverage of deaths. So when we are comparing two period of time, particularly over time, we have to be extremely serious. For example, if we want to do a baseline survey before COVID and now after COVID, we have to be really careful about, we have to really adjust the reporting level. Similarly, if CRS has some issues over the space, as we have seen that CRS data collection, a lot of protocols are established by state level, and they are not uniform across countries, across the states. So therefore, again, when we compare two states, we have to be careful. For example, in some states, say ANMs are responsible for collecting that registration data, but not everywhere. So that is just an example. Protocols are not equally similarly maintained over the states. Then reliability. Data should be able to reflect the stable and consistent data collection should be done. And again, here also CRS has some issues. Timeliness, we know that what Professor Rao has said, in case of CRS, we have two problems of timeliness. One is that delayed registration at individual level, and again, publication, and also a matter of concern. And a lot of time, different states does not give their data at correct point, regularly to the central government. They don't pass through from state to central level. So not only delayed registrations happens because of several issues at the field level, but also publication very often misses. In some of the CRS report earlier, some states were missed just because for that year they didn't send the data. Relevance, as I said, CRS data is extremely relevant, but of course it will depend on the completeness, as we discussed. If data is complete, then only we can use the CRS data. So from Professor Rao's talk, we found that there has been great issue of coverage, lowest in most recent time in Jammu and Kashmir, to high in southern states. Some states are doing even better, more than 95%. Another one issue I observed that CRS is giving in A6 segregation, but still not enough for usual mortality data mortality analysis, particularly life table calculation. We because life table calculation being the basic tool and easiest tool to interpret for the policymaker, we always need CRS data for 0 to 1, 1 to 4, and then every 5-year age group. But CRS reports are not giving those data. There has been huge underreporting of under 5 children in CRS, which is true because, as I say, a review of literature and our own study shows that people go for registration when there is some kind of compulsion, particularly property registration or marriage related issue or something. For children, and people does not want to register because there is no economic benefit, no enrollment benefit, or it has some negative psychological impact. So in CRS, there has been huge underreporting under age 5. There are a lot of administrative, technical, and societal challenges for CRS. There is lack of harmonization of the system for the states of India. Also, we see that in his speech, we see that there are some states where more than 100%, and in urban areas particularly, more than 100% reporting of death has been happening, which means that CRS data is not compiled well according to the place of residence and place of deaths happening. So if urban population, in urban place, if people are coming for treatment and they are dying, they are reported in that place itself. Therefore, there is more than 100% reporting of data, which is technically not correct. So why CRS data is not still complete in India? These factors we can divide it from review literature, and one of my PhD student and Mr. Krishna Kumar, who has been doing this on CRS data, we found that there are basically two types of aspect. One is community aspect and another is administrative aspect. In community, we see that there is lack of awareness for death registration. While birth registration is very popular in India now, even in her remotest part, because of school enrolling, because of government facilities or schemes, death registration, people are not aware and they are not interested unless there is a change in property, there is a need of property transfer, or there is a need of pension and scheme transfer, something like that. And also, it has been found that people in general find very unfriendly the process of registration at the office, and very often because of several issues, they delay in registration. An administrative aspect, basically, because as Professor Rao has also showed that different states allocate different amount of budget. They have their systems are quite although similar, but still within that still quite different, and lack of dedicated staff has been observed. Lack of dedicated fund has been observed, and finally, technological innovation is a big issue. Very often, and the people who are at civil registration system, they are not meant for register. They are say health worker, they are teacher or local panchayat people. It is this registration is not their primary job. They are doing just as a extra. So they don't get enough training, and they don't have technological innovation, like lack of computer, or they don't have enough training for handling computer and so on. So these are the reasons why civil registration system has not been yet fully complete in India. But what we understand that for India, if we want to reach 100% coverage of civil registration system, there is no lack of resources or money. We have enough expert, we have enough money or system. only thing what is missing is political will. We don't need to start from zero. We need to just invest money, or we need to invest on training to make it better, complete. When we have census, one of the biggest census of the world, and which is also consistently happening, and we have biggest surveys of the world, NFHS, DLHS, some of these are very big surveys. To handle such kind of surveys, we have experts, we have money. So why not we are not focusing on civil registration system? A lot of people may think about that there can be ethical issue, but that is not true. Or if it is true, like a lot of people during National Population Register, they were concerning that this kind of data can be misused, but that can be always handled, because it has, the SRS data has been handled in that similar fashion, or NFXs. When we think that if in certain states SRS and CRS have similar level of coverage in mortality statistics, what is so the question is, should we really continue with SRS? SRS is not able to give at district level. SRS is becoming subject to extreme sampling error. Also, lesser coverage. There are many states where SRS are giving sometimes very unusual health data. So I think we now need to think that whether we can merge both this system to generate high quality mortality statistics at local level. At the moment, we have many, as we discussed, in even NSSO data collects information on mortality, but those data are hardly analyzed, hardly used. HMIS is collecting mortality data, but those are subject to high under reporting. Then SRS. So what I find that there are so many systems, but everything is far from perfect. Maybe or far from usable. Only 2 or 3 data sets are usable. Maybe we should think about combining SRS and CRS together, or expanding SRS to CRS level, and then also keep NFHs, of course, to measure the data quality issues. It may sound very very crazy at the moment, but I think India has to move towards a complete registration system to meet future disaster, to evaluate the quality of inequality at local level. We still do not have life expectancy by socioeconomic characteristic at district or at state level. If we are collecting CRS data with 1 or 2 most important socioeconomic data, for example, education and wealth index, not wealth index, some kind of measure of income, it or caste, so it can give detailed inequality that actually is existing in India.
Thank you, Dr. Nandita. Can you please wind up? Yeah.
This is my final slide. So a complete registration, like we have not discussed about National Population Register data, but CRS along with NPR, National Population Register, can solve all the data related issues related to fertility, mortality, and migration. And we do not have enough research on CRS. So our young generation should come forward to do more and more research on civil registration system data. Thank you.
Nandita, may I request Dr. Chalpati Rao also to switch on his camera? We have a few, before we actually have 5 questions, and I do want to justify the time that our participants have given for this important webinar. Dr. Rao, the first question is, what strategies are you implementing to ensure consistency of data at different service delivery points? So this is by Dr. Gordon. So what strategies are you implementing to ensure consistency of data at different service delivery points? Can I read out all the questions, or I take it one by one? Maybe, okay. Can't hear you. Sorry, if you're on mute, please unmute.
Yeah. So I understand that service delivery points might possibly mean the district government, or the state government, or the national government. primarily. And the other service delivery points might be the Ministry of Health or the Ministry of Planning and Statistics, where they do some kind of resource allocation. A third service delivery point might be the institutes of medical research, where they use these data to guide their epidemiological and demographic research, as well as the institutes of population delivery. Population research, such as the IIPS, etc. So in terms of strategies to improve the availability of data to these various service delivery points, I suppose the strategy which I had laid out in my talk about strengthening the compilation and production of statistics, reliable statistics at the level of the district is a primary function. And the strategy to achieve that is to first look at the quality of the data that is available at the district level, examine it for its gaps and for its inconsistencies, and where there are data gaps and inconsistencies, go further to see what are the systemic attributes that are resulting in these gaps, whether it is resources, whether it is community participation, whether it is training of the functionaries, whether it is lack of information on the cause of death, whatever it is. So those strategies to strengthen quality at the district level and at the state level. And once you have quality data from the source, then any of the delivery points can use it. So quality civil registration statistics are available to all data points, service delivery points.
Okay, thank you, Dr. Rao. The next question is, thank you, Dr. Professor Rao. What about temporal registrations of deaths, deaths by month or week or registration occurrence, particularly important for excess mortality estimates and ILI monitoring? So this is by Ariel Karolinski.
As I had presented in the slides, the death report includes information on the date of death. So by design, the data on all these thousands and hundreds of thousands and millions of deaths that are being compiled every year in the civil registration system technically are being captured according to the exact date of death. Now, it's a matter of access to the data to be able to evaluate the availability or the incidence of mortality by week and month and quarter, etc., for COVID mortality estimation. India is a vast country, and compiling data to this level of detail and is a challenge. And as Professor Saikia had also mentioned, that there are varying levels of efficiency and varying levels of timeliness in the reports from different states. Measuring COVID mortality is a concern for, I think, all researchers in India as well. And I anticipate that the civil registration system will produce its report for 2020 and 2021. And then, depending on the government's priorities and intentions, access to more detailed data would be, a matter under their jurisdiction.
Thank you, sir. The next question is by Sadaf Nas. He has asked, about the Dr. Rao, during your presentation, you had mentioned about Gujarat and Haryana as showing lower coverage of hospital-related deaths. Although Gujarat and Haryana are very much developed states compared to the EAG states in India. So what could be the possible reasons for that?
Well, I anticipate that there's some degree of an administrative error in this part. I can just relate an example of when I was working in the statistics on causes of death in Andhra Pradesh. I found where I visited several hospitals that had not been reporting the data, that the certificate copies were stacked and available. They had not been submitted to the municipality. And when we went to the municipality, we found the bundles of certificates which had not been submitted to the state. And where they had not been submitted to the state, they could not have been submitted to the center. So it is quite likely that information would be available at the hospitals. There needs to be some strengthening of the bureaucratic machinery and computerization, which can redress these gaps in the system. But because, as the questioner had rightly pointed out, both Gujarat and Haryana are well-resourced states. So plugging this gap is not something, which is unfeasible, so to speak.
Sure. The next question is from Dr. A.K. Sharma, who has asked, so can we use CRS data for study of mortality and trends at the state level, given that now there is an improvement?
I would think so. In fact, that is what I had attempted and published recently. There are gaps in the data, as we know, and as I had mentioned, that there are gaps in the under 5 mortality data. There are gaps in female death registration. There are potential problems with delayed registration. The more access that is given to detailed records, the better will be the analysis. The identification of specific biases and correction of those biases can be possible only if access to detailed data is made available, for which there has to be greater emphasis on computerization of the complete birth and death reports, all the variables, and there has to be a greater attention at the local level to evaluate the quality of these reports and the data, and to identify, and improve the basic level information that's coming in. In summary, it is possible, and one must attempt to use the CRS data, and one must try and ask the state registrar to give age and sex specific deaths at district level, not just the total deaths, so that more detailed analysis can be done, and so on and so forth.
Sure, thank you, sir. The next question is from Dr. Ganesh Kumar, who has complimented both Professor Rao and Professor Saikia, and he has specific questions on whether your perspectives on the quality of causes of death data in the CRS.
Yes, so as I had shown again in the death report, there is one column for reporting the cause of death, and this is reported by the family member. Now, no one has actually analyzed that data in detail. In many instances, the family would report a specific cause in case their relative had accessed some medical attention either at death or during the terminal illness. So even if that death hadn't been medically certified, there could be some valuable information. And I have seen an analysis of the data for Punjab state, in which there was reasonably, decent information. I would not say good information. On at least 50 or 60%, there was a specific cause that was mentioned in the Form 2 death report. In terms of the quality of medical certification, I would say that the death certificates from tertiary level institutions in India are of a very high standard. There are death certificates which hold even up to 7, 8, 9 causes of death, in which all the detailed underlying antecedent consequences, complications, immediate and contributory causes are mentioned on the death certificates. We do have training at the MBBS level where physicians are exposed to the requirements for medical certification. And if there is greater attention paid to death certification within hospitals and hospital departments, it's not rocket science. No, there is tremendous scope for having good quality data, and I would say that even the existing quality has not been fully examined to understand its attributes. Yes.
So there are more questions. I'm going to club 2 or 3 questions, and then probably it would be easier. So one question is from Dr. Sibin George, who has asked about few states have shown more than 100% registration in CRS system. How do we answer the numerator and denominator validation? And Dr. Krishna Kumar has a question on how can we generate reliable data on infant deaths. So then one more to go with it about, no, just two? Okay, so please go ahead. Okay. No, go ahead, sir, please. Sorry.
Okay, so the denominator problem in the 100% or more than 100% is because the denominator is derived from the SRS rate. And as we have shown in some of the slides, the SRS point estimate could be an underestimate. As you know, the SRS point estimate of mortality has a wide sampling error. That means the 95% confidence interval of that death rate from the SRS indicates that the actual value could be anywhere between those two, the two limits. So if you have a true death rate or an age-specific death rate, depending on whichever indicator you're taking, and it has a wide confidence interval, then, but you're using only the point estimate to derive your denominator, the point estimate could be even at the two extremes. So the problem of 110% and 115% could be because of the point estimate being an underestimate. The second issue is what Professor Saikia had mentioned, that in the CRS, especially if you look at data for Puducherry or Chandigarh or Delhi, and even for Goa, there are a large number of death reports which are from patients who've come from neighboring areas, so individuals from districts in Tamil Nadu that are bordering Puducherry, or individuals from Haryana or Punjab who are visiting PGI or somewhere. So the numerator is inflated, and that also can create, this problem of more than 100. These are the two most common, or plausible explanations, for that phenomenon. The second question which you had asked, I have forgotten.
The reliability of infant death data.
Yes. So the infant deaths, as I had mentioned in my talk, reporting of infant deaths is a sensitive matter for the family. The second issue is the reporting period is 21 days. And as we know, most of the infant deaths or even the neonatal deaths are concentrated within the first 7 days or even the first 3 days. And thereby, there is a need then for both the birth and the death to be reported. So it becomes easy to escape both because the reporting period, has not been, you didn't even reach that stage, where you needed to report a birth when the death had occurred. So I don't need to report both. And it's a sensitive event. So families don't want to do that. The strategy would be to establish a community level reporting system through the ASHAs and through the ANMs and through other community representatives who desensitize this matter and enable notifications of stillbirths and infant deaths, not by the family, but through these third parties, to the registration office to improve the quality and reliability of infant death reporting at the local level. We need to undertake some qualitative studies, and some pilot projects. And unless we engage in that manner, we may not have a proper answer to this very important and relevant question.
Sure.
I want to add, Dr.
Please
Rita,
go
I
ahead.
want to add some
Please go ahead.
points for both. Yeah. So I think the first question is excellent question about this numerator and denominator. And, even if we go for 100% coverage of civil registration system, we will have this denominator problem always, because unless we emphasize a continuous national population register, because from civil registration system, we are able to cover only fertility and mortality, not migration. And say, think about that, we can, instead of SRS, we can also derive denominator from census, as like, base population and then project. But again, this is a huge subject to like changing migration. So if we want to really do final solution of all these three, and they are totally interconnected. If we avoid migration, we cannot build, good denominator. So I think for long term, we always need both complete civil registration as well as national population register, so that every time, we have real time continuous base, denominator. And about this infant and mortality improvement, I think in addition to community level reporting, there can be some technological addition, like, register, not necessarily to go to that office and register, but doing online registration. Now everything is happening online, and why not mortality data cannot be done? So because a lot of time people are suffering this kind of tragic death, and they don't want to go within 11 days or 30 days, they don't want to go outside. That's how they are underreported. So maybe partially it can be solved. Thank you.
Okay, so there are a few more questions. If that can be addressed briefly, it would be really helpful, because we are over time now. We are almost 4:25.
I have time.
Yeah. So the question is about, from Dr. Mohanendran Nair, ki by strengthening our CRS system in quality and coverage, can we think of closing the SRS? And the second question is, how is it possible to calculate the district level mortality from the HMIS data? So that is from Dr. Nikhilesh Parchure. So both, I think, Professor Saike, if you can answer that.
Yes, I think, instead of closing completely, what I think that merging both will be good, because what SRS people are already expert, like staff and all the people, like they're quite experienced with this system, although it is a more service-based approach. So I think that whole system can be translated or merged, and the same money, like, because CRS is suffering basically lack of fund and staff, trained staff. So if SRS people are further expanded, it may sound very crazy, but this is what I feel. If we can go for 100% CRS, what is the need of SRS? SRS is not giving data at district level, and district is now district as well as further going down below. Block is now, all the political systems, government, schemes, fund, everything is happening at block level. Why do not we should not we think about that? So that is one. And for HMIs, again, I think, even after so much of investment training, HMIs will always suffer from mortality data, because it is linked with their performance. Because if their mortality data are correctly reflected in HMIs, there will be always question about the performance of that health management, health system, what is happening. So there will be always kind of underreporting. So I think, I think focus more on.
Thank you. So Dr. Rao, I have two questions, so that, and then probably you can elaborate during that. Because Dr. Abhinav wants your opinion on estimating excess mortality during the pandemic from panel studies by private survey organizations, given this partial data vacuum. And Dr. Mukherjee has a methodological question for you in terms of, he's mentioned that by showing correlation between the two methods, you try to show agreement. Why can't you show the Bland-Altman curves for the same? Thank you.
Okay, so the response regarding the HMIS is that the HMIS does not cover private sector institutions. So it will always be biased because it would not have information from private health sector institutions, which actually provide a lot of healthcare in India. And it's very difficult to get private sector institutions to comply with government reporting mechanisms. So that was one. The second question was about using panel surveys to estimate COVID mortality. You know, um, I think some of this has already been attempted, and there have been some publications in recent times which have used information from these panel surveys to estimate, excess mortality. Without talking too much about that, I will say that, I have my reservations, and these reservations are purely on account of sample size, you know, because I have even seen one paper which had information about, I think, 1,800 deaths, and then used that to estimate that there were 4.1 million deaths. So my mind boggles as to the number of the scale factor between 1,800 and 4.1 million. So I mean, the largest panel survey we have is the SRS, and we have found so much of sampling error and bias even in the SRS itself. Ideally, we should have information from the CRS along with a survey. And we need to conduct the dual record system analysis, where we link the records from the survey and from the CRS using the Chandrasekhar-Deming technique to identify the missed events from both the systems and thereby derive the overall total estimate of the deaths in the population. So a panel survey alone would be affected by sampling error and other forms of bias. That's my opinion, and I'll be happy to be proven wrong. I think there's it's an open field. Your final question again, please.
Sorry. One second. Yeah, so the final question was on the methodology part. By showing a correlation between two methods, you try to show agreement. Why can't you show the Bland-Altman curves for the same? So that was the question that was raised on your analysis.
So I suppose the question is about the agreement between the ORGI method and the Adair-Lopez method.
So there is no clarity, but then I understand probably that is the case, where you have shown correlation between the two methods in showing the agreement in the mortality data.
Yes, I mean, in some ways, both the methods are based on similar principles of evaluating the completeness based on an expectation of deaths according to accrued death rate. The difference lies in the fact that the Adair-Lopez model also takes into account the population age composition, because they have found that registration of deaths in the elderly and the under 5 is also, the completeness of registration at those ages is also related to the overall accrued death rate. So those are additional variables that have been introduced into their model, but the underlying concept driving both is the same. So now that there is agreement, or I mean, that gives a sort of a notional understanding of the level of registration. I would be cautious in using those levels of registration in actually correcting the data, because they are for all ages together, and we know that there are age-specific variations in completeness. So applying an overall level of completeness to inflate all the deaths, it doesn't sound very reasonable to me.
Thank you so much, Professor Rao and Professor Saikya. It's been a pleasure having you both, and the interest generated is immense. So we have lot many questions. I request the participants to please email our speakers so that you get answers to all your questions that you have. So now we come to the end of the session, and useful insights towards strengthening the mortality status from the CRVS system. Thank you so much, Dr. Rao and Professor Saike, and all our participants for being so engaging. Thank you so much.
Thank you for inviting. It's a great pleasure.
My pleasure. Thank you very much. And my regards to all the participants.
Thank you.